I'm sure you're going to have a lot of questions for Dr. Schweitzer at the QA period. So it's really a distinct pleasure and privilege to introduce our first keynote speaker, Dr. Paul Schellhammer. So Dr. Schellhammer is really the epitome of a physician scientist. He was the chairman of the Department of Urology at the Eastern Virginia Medical School. He's the former president of the American Urological Association. He's received numerous accolades and awards and has been involved in many of the major treatment advances in prostate cancer, including some of the original studies of Provenge, the immunotherapy agent. And he also has a quite unique perspective, being diagnosed himself with prostate cancer. So I think we're going to hear some about that. Paul?
Thank you. Thank you, Pete. And it certainly is a pleasure to be here with you this afternoon. And I am here to tell you a story, my story. And often when I do present this, individuals will say, well, why are you doing this? Well, there are a number of points I could discuss, but I think two come to mind immediately. One, as I review what I have reflected on in the past and made decisions about, it will help my decision making in the future with the options of therapy that you've heard this afternoon and this morning explained to you. And two, hopefully, for many of you, some of what I have reflected upon and the decisions and the information I have used to reach my decisions will apply in some cases to your journey through prostate cancer. So I call myself a participant, and I will get back to that again, as opposed to the usual moniker of survivor. Now, Paul Lang and I did reflect on the other side, and this monograph is available out in the lobby, and I encourage you to retrieve it on your way out if you have already not obtained it. So I'll start with a pessimistic satirical statement by Voltaire, which you can read and understand that we have come a long ways, although he did have many pertinent points to bring forth. And it fits in well to Dr. Montgomery's precision medicine statement, how we are now, while we know more about the diseases and more about the medications and pharmacy, we are learning more about the host in whom the disease occurs, and precision medicine will be the direction of the future. So why participant? Well, I'll give you a laundry list very quickly of what I have experienced in my prostate cancer journey, and you can read there the surgery, the clinical trials, the various radiation therapies to the prostate bed, for breast resolution of pain, stereotactic cyberknife radiation, which I'll discuss further, and likely in the near future, radium-223 or Xofigo. With regard to pharmaceutical agents, I also have run a laundry list here, and excuse the spelling of ketoconazole, but I have had and experienced all of these that are listed, in addition to immunotherapy, Provenge, and the bone protective agents that are available as well. So every prostate cancer story starts out with a PSA, and in 1991, as a 50-year-old, I was an early adopter and had a PSA of 2, which I was delighted with because the magical 4 upper limit of normal was then thought to be the absolute harbinger of truth, above which you had trouble and below which you were safe. And you can see my PSA varied a bit, and I went on Proscar because of some aging prostatic symptoms, and I had an appropriate fall. And then there was a 3-year hiatus before I had another PSA that was back to the 2.57 baseline, which was not appropriate with Proscar. I discontinued that medication. PSA continues to rise, and a biopsy was obtained. I have that heart symbol there because during that time lapse, I was the victim, if you will, of the other common disease of aging male, cardiac disease. I endured a cardiac event, which fortunately was promptly stented. And just a brief thought about my psychology and reaction to two diseases. With regard to the heart, it was certainly an unhappy event, but with diet and exercise and lifestyle changes, I felt I could form a partnership and go forward optimistically into the future. Contrast that with the diagnosis of prostate cancer, where I was very much concerned, felt betrayed, if you will, to some degree, and wanted to get this resident alien apart from my body. Even though intellectually, clearly, as is the case with any male with prostate cancer, cardiovascular disease is the primary cause of morbidity and mortality, and certainly for me was a much greater risk. But nevertheless, the emotional standpoint is one that we as physicians need to recognize, and patients need to recognize. The cancer word is a frightening one indeed. Now, PSA will be the subject of discussion and will be the subject of much controversy into the future. And there may be risk-adapted screen strategies that are more appropriate. And I just ask you to look at the first line, because we know now that the median PSA of a 50-year-old is 0.6. And we could very easily look at the men above 0.6 more carefully, because it's in that group that the majority of significant prostate cancers will appear. However, 20% of men with a PSA less than 6 will still be at risk, and so that really, although risk adapted, doesn't give you the certainty and the warm fuzzy feeling of safety. Obviously, we will require other biomarkers in addition to PSA into the future. So I had the biopsy of prostate cancer, and the decision, like all men, is what therapy to embark upon. This was in the year 2000, and my decision was to proceed with surgery, and there are a number of reasons for that you can read, but clearly removing 1 billion or more cancer cells, to me, in a 2 to 3 hour operation was very attractive, and defined pathology for further potential therapy was equally attractive. Here I am with my surgeon, Drs. Lang and Ellis, and I looked pretty happy for a first post-operative day in the year 2000. And there was my unhappy prostate, a very, very good specimen with lots of soft tissue around it, and the pathology had good and bad readings. The good reading was it was organ confined. The worrisome was the 4+3 with possible Gleason 5 as well, so you could package that into a Gleason 8. Now, I thought Dr. Lin made a very interesting statement, and it covers what this particular slide wishes to demonstrate to you, that pathology is a subjective art, and Gleason score is very powerful, but it's not the end-all and be-all. I had the initial reading after my surgery, as noted on the top. Subsequently, as part of a clinical trial, this material was gathered for rereading, and obviously there was a significant stage and Gleason score change. So the emphasis is that it's good to have more than one individual review your pathology and know perhaps more clearly what you have in store for the future. So post-surgery, my PSA fell appropriately, but then within a year began to rise, and it was clear that something needed to be done in my mind, and I chose the route of salvage radiation and added, only because I felt that if androgen deprivation therapy was effective with external beam in treating the bulky primary, gosh, that should be effective as an adjunct to salvage radiation. That question is still uncertain. It's being tested in clinical trials, and so it certainly does not meet any level 1 evidence criteria, but that was my decision. And actually, my PSA, as you can see, from 02 to 05, held pretty steady and satisfactory, but in 06 began to rise again, and it looked like androgen deprivation therapy perhaps was again on the horizon. But I really wanted to avoid ADT because of its side effects, and I felt a clinical trial would be appropriate at that time. The clinical trial was for a drug called lapatinib, which interestingly, under the proprietary name Tykerb is now approved for breast cancer, but it really didn't make any impact on prostate cancer. And you can see my PSA continued to rise, and so the time was now for combined androgen blockade, and I decided to add Avodart to the mixture in hopes of going on intermittent ADT and being able to extend a drug holiday with the 5-alpha reductase inhibitor. Just a word about clinical trial experience. I am a strong advocate of clinical trials, enrolled many patients on them, but it really presents to the patient, I'll say often, an unfriendly environment of testing and rigidity. And fortunately, here in Seattle, you are blessed with clinical trial possibilities that very often are not available to more peripheral areas that require travel and a lot of inconvenience. So I initiated CAB and Avodart triple androgen deprivation therapy. My PSA fell, but as you can see, the PSA did not reach an undetectable range, and that's a warning for failure of the therapy to accomplish its best outcome. And no surprise, then the PSA began to rise. I had anti-androgen withdrawal. My T in all of this, you have to recall, was appropriate. It was castrate. And in 2008, there weren't any other options other than docetaxel chemotherapy, which I was not interested in pursuing at that time. So at the advice and counsel of Dr. Myers, who you will hear from next, I began a rather unconventional therapy of estradiol or estrogen, but TD stands for transdermal, not oral. And I'll just put a push in for estrogen now because I think it's overlooked and underutilized, and let me give you a few reviews of that fact. This is somewhat dated, but as you can see, it makes the point that estrogen, of all the ADT possibilities, is way down on the list and very rarely used in the USA. Looking back at the initial estrogen trials in the 60s, it was noted that men who took estrogen had a lower prostate cancer mortality. Now, unfortunately, because of the side effects of estrogen, they had more cardiovascular disease and therefore a higher overall mortality. But DES, as this statistician who monitored the veterans trial noted, acts directly on the cancer cell in addition to inhibiting testosterone secretion. So that's a tantalizing piece of information. And also, the side effect profile can be eased quite remarkably. So if you decrease T, as is the case with ADT therapy, there will be no aromatization of T to estrogen. And the side effects of low T are listed, and the side effects of low E are listed because you are a dual hormone-deprived eunuch. It's better, in my opinion, to be a mono-hormone-deprived eunuch, thereby solved by giving E, and you still have low T because E will suppress T. You will still have those side effects, but osteoporosis, lipid changes, hot flashes, sometimes even the thought of cognitive dysfunction and libido are altered in favorable way with E. So let me show a few animal studies because it's always good to look at our rat friend who brings so many good things to our daily menu. So estradiol facilitates recovery of REM sleep. It reduces HOT. It's never been absolutely proven with level 1 evidence, and you can see these individuals misidentifying body parts of the elephant because the elephant in the room is perception, and perception is riddled with bias, and it also, frankly, is the reason why a informed decision between a patient and a physician is such a flexible issue based on the physician's mindset and the patient's mindset and how they will interact with one another. I will close in the next 3 to 4 minutes just by looking at some of the terms that are associated with cancer. Cancer has its own vocabulary, its own lexicon, and sometimes I think the impact of the words might be misconstrued and not lead to best thoughts and outcomes. So survivor. Any soldier's been through a battle, any patient who's been through therapy and comes out on the other end feels they're a survivor. But we know in medicine survivorship is time limited, 2 years, 5 years, 10 years. And I like, again, the thought of participant, because then with recurrences, the patient really needs to do his homework, needs to interact with his physician, needs to know the playing field and participate in decision making. War. Well, war is a metaphor for business, it's a metaphor for sports, it's now a metaphor for medicine, and the date is wrong, it's really 1972, but Nixon signed the National Cancer Act and officially declared war on cancer, and actually said that we will defeat this enemy within 5 years. Well, how wrong was that? But war is debilitating, energy consuming, resource consuming, and long wars all the more so. And prostate cancer, fortunately, is a disease of long natural history, and if one is at battle every day, one does not learn to live well with cancer because they're exhausted with the constant thought and competition that goes through their mind on a daily basis. And so Mukherjee, the author of The Emperor of All Maladies, I think said it well, and he said the war on cancer may have to be won by redefining the meaning of victory, which doesn't necessarily mean cure. We want to thrive as well as survive, so thrival and better quality of life is important, and George Fisher may have pushed it a bit when he made this statement, but nevertheless, you've heard it said otherwise, when there are clouds on the horizon, you learn to dance in the rain, and you make the best of what you can with what you have. Finally, cure. I've felt this way with the first diagnosis. Every patient feels, is there some pharmacologic agent, some surgical procedure that will cure me, get this in the past, let me go on life as it was before the diagnosis. And for some fortunate individuals, that may be the case, although we never really know if the patient is cured. He just happens to be free of disease as best we can detect it. We have to remember the Latin root for cure is curare, which means to care for, a much more powerful implied statement with regard to the likelihood of the need for further care and further issues if patient recurs in the future. So, prostate cancer is often not cured. We know that. It's hard to completely eradicate often, but it can be reduced to a chronic disease which may be controlled and really at our age mimics life.